Bismillahirrahmanirrahim. Today's my discussion topic is recurrent miscarriages. We will discuss in this presentation what is recurrent miscarriages, cause, causes, symptoms, and treatment. I start with this quoting from T.G. Thomas. He says that I recall nothing which in times past has caused me more anxiety and doubt, or in regard to which I have found it more difficult to get any satisfactory rules from books than the treatment of abortion. The recurrent miscarriage, as we know, we come across cases in our day-to-day practice, and it's a very important problem for the couple because it has got effect on the psychological as well as the social impact on the couple. The frequent questions asked from the clinician are how it can be avoided, what will it happen again, why did it happen, could have been avoided. Now this problem has got psychological impact on the couple, which because it results into many psychological events like anxiety, depression, social problems among the couple, problems in the family, and ultimately sometimes it may lead to the separation of the couple. On the part of the physician, we know that this is a very complicated problem because most of the time we are worried about the diagnosis as well as the treatment, because in majority of the cases, even after doing specific investigation, we are unable to find out the cause, and it just really becomes difficult while counseling the patient regarding the unknown cause and its treatment. Now, this slide shows the summary of recurrent pregnancy loss defined by different organizations and societies. We usually follow the RCUG guidelines. So, according to the RCUG guideline, the recurrent miscarriage is the condition whereas there are 3 consecutive pregnancy losses up to 24 weeks, and it's not defined whether it's a first trimester pregnancy loss or second trimester pregnancy loss. So it's the 3 consecutive loss of pregnancy before 24 weeks of pregnancy. Now there are subtypes of this recurrent miscarriage. There's a primary recurrent miscarriage and secondary recurrent miscarriage. The primary recurrent miscarriage is the condition where the couple never had a live birth. It means it's from the start of their reproductive life, they are unable to get a live full-term baby. Secondary miscarriage is the condition where the couple had repeated losses following a successful pregnancy. Now, there are many risk factors associated. There are certain causes and then there are rare risk factors. And some of the risk factors, if we avoid those risk factors, we can manage the recurrent miscarriages in some of the couples. The top of the list is the maternal age, then smoking, then alcohol consumption, previous pregnancy loss, then BMI more than 25, and environmental factor. These are new. There are numerous risk factors, but these are very important risk factors associated with the recurrent miscarriages. Amongst these all risk factors, the most important risk factors are the age and previous pregnancy loss. These are the independent risk factors in causation of the recurrent miscarriages. As we know, as the maternal age advances, there are chances of having abnormal oocytes, and number of the oocytes also decrease. So as this increases, the abnormal karyotyping in the cells occur, which results into the abnormal formation of the fetus, resulting into the miscarriages. As we know from this chart, the chances of miscarriages that is the first, second, or third, increases as the age increases. It has been shown that after three miscarriages, the risk of having miscarriage is about 31 to 45%. Here we can also see that as the age increases, if women beyond 40 years of age, the chances increase, and at the age of 47, there are 93% chances of having miscarriage. This also shows the increased incidence of miscarriage as the age increases. Now there are certain factors which are possible factor, and there are explanations for those factors. There are doubtful factors, and their condition is sometimes unexplained. And here you can see that about 40 to 50% of the cases the condition is unexplained, because we, in spite of advising certain investigations, we are unable to explain the cause of the problem. Now here you can see the causes. The recurrent miscarriage at the top of the list is the blood clotting, then hormonal factors, anatomical factors, genetic factors, and unknown. Unknown comprise about 40 to 50% of the cases, while the clotting problem like antiphospholipid antibody syndrome, or the other hormonal causes like diabetes mellitus, thyroid problems, as well as hyperprolactinemia. So major bulk of the causes lie in the clotting, hormonal, as well as anatomical problem. Anatomical problem comprise anatomical defects in the uterus, which may be due to the uterine malformation, may be due to the intrauterine adhesions, or the or submucosal fibroids. Now, this table briefly explain the causes trimester wise. These causes have been explained on the basis of certain investigations. Now, the chromosomal abnormalities of the fetus occur usually in the first trimester, or may occur in the second trimester, and may result in first trimester. 70% of the miscarriages are due to chromosomal abnormalities, and the commonest abnormalities are trisomy, polyploidy, and monoploidy. In about 2 to 6% of the cases, the parental chromosomal abnormalities may occur, and that can lead to first trimester miscarriages. And the commonest one is the balanced reciprocal or Robertsonian translocations. In about 10 to 15% of the cases, the uterine abnormalities are responsible for these miscarriages, and the commonest, mostly these occur in both the trimesters, like these can occur in the first trimester or the second trimester. The commonest uterine abnormalities are uterine septa, bicornuate uterus, fibroid polyps, and uterine adhesions. Cervical insufficiency causes second trimester miscarriage, and causes may be different. In about 5 to 20% of the cases, acquired hemophilia is responsible for the miscarriages, and the commonest for the antiphospholipid syndrome. And this problem can occur in the first trimester as well as in the second trimester. Then comes the hereditary thrombophilia. It has been shown that there is weak association between second trimester miscarriage and inherited thrombophilia, and sometime these may be due to factor 5 laden gene mutation, prothrombin gene mutation, and deficiencies in antithrombin protein C and protein S. Amongst the medical disorders, the medical disorders account for 15 to 20% of the cases, and the commonest one are the hypothyroidism, diabetes, uncontrolled diabetes mellitus, hyperprolactinemia, and the abortion or miscarriage can occur in both the trimester. These are some pictures showing uterine abnormalities like diadelphys uterus, arcuate uterus, septate. The commonest problem are associated with the subtate uterus, and the treatment is also available. Diagnosis can be easily made by doing 3D scan, and resection of the septum results into improvement in the conception. Now there are doubtful factor. Doubtful factor in a sense that there is no strong evidence which show the association between these conditions and the miscarriages. But there are sporadic studies which shown that these problem can have link with the causation of recurrent miscarriages. The polycystic ovarian syndrome, ovarian reserve, luteal insufficiency, male factors, and infections. Now, it has been shown that the polycystic ovarian syndrome is associated with the high incidence of miscarriages in the women who conceive, and that could be related to the hyperandrogenism. Luteal insufficiency, in the past, it was supposed that the luteal insufficiency could be a cause of recurrent miscarriage, but there is no specific diagnostic criteria for this condition, and there is no strong evidence to show that there is some relationship between the recurrent miscarriage and luteal insufficiency. Male factors like the sperm DNA fragmentation has been associated with the recurrent miscarriages, but this also condition is very difficult to diagnose, and treatment is not possible, so it comes in the group of doubtful causes. Infection, it has been shown in many studies that the uterine infection, that the chronic endometritis can be a cause of recurrent miscarriages, and there is no strong evidence, but strong study is going on which will show that whether there is any association between chronic endometritis and recurrent miscarriages, and this is called SUM trial. SUM trial means chronic endometritis and recurrent miscarriages. The trial started in 2018 and it will end into 2024. This trial is investigating whether the treatment with antibiotic, that is doxycycline, before conception improves pregnancy outcome for women with recurrent miscarriage and chronic endometritis. It's a prospective multicentral double-blinded randomized controlled trial. In this trial, women with a history of 2 or more consecutive pregnancy losses and who test positive for chronic endometritis will be treated with either 100 milligram of doxycycline twice daily, or a placebo for 14 days, and their pregnancy outcome will be compared. Now we always start with these 3 scenarios we usually come across in our clinical practice. In case number 1, 32 years, gravida 4 plus 0 and plus 3. It means she's gravida 4, and there was 3 previous pregnancy losses at about 10 weeks of gestation. All the first trimester miscarriages. She's worried about the future pregnancy. No medical and surgical problem is find out. And this condition is the primary recurrent pregnancy loss. Second case is a 28 years gravida 5 para 1 with having three miscarriages and 1 preterm labor, and she's having none alive. She comes at 18 weeks of gestation. The first baby was preterm birth at 30 weeks, which ended up with neonatal death. 2 second trimester miscarriages. 1 first trimester miscarriage. No medical surgical problem. The case number 3 is the 41-year age gravida 6 para 2 having 3 miscarriages and 2 alive children. She comes at 14 weeks of pregnancy. There are 2 full-term live babies followed by 3 first trimester miscarriages. She is hypertensive. Her BMI is 29 kg per meter square, and their cousin marriage. Now, in this third case, we can see that there are some risk factors which can be associated with her recurrent miscarriages, because her previous pregnancies were full-term and normal. As the age increases, the chances of having miscarriage also increase. So 41 years age, the chance of having miscarriage is high as compared to at 30 years of age. Then the second risk factor in this patient maybe the BMI, that is 29, so more than 25, so it is also risk factor. The third risk factor is the recurrent miscarriage. Recurrent miscarriage itself is a risk factor for having the future chance of miscarriage. Cousin marriage is not a, it has been, is had been shown there is no association between cousin marriage and a recurrent miscarriage. So this is not a risk factor. Some people have proposed prognostic prediction tool for a live birth among women with recurrent pregnancy loss. This is called the prognostic tool, that is a Loin Brigham, can be used to provide an estimate of subsequent chance of live birth in couples with unexplained recurrent pregnancy loss. The prognostic tool took into account the unique contribution of different risk factors, including in the history, maternal age, number of pregnancy losses, whether primary or secondary pregnancy loss, and positive pregnancy loss workup. So, all the factors, history and investigations are included in the tool, and then prediction of the future pregnancy is done using this prognostic tool. Then the diagnosis usually is made by history, examination, and investigation. In the history, do full we should take full medical, obstetrical, gynecological, and the family history. Information on the lifestyle of male and female is very important, because as we have seen that smoking and excessive alcohol consumption may be a risk factor in this condition, than excessive exercise, being overweight or underweight. And then in the history, emotional impact on this problem is also inquired. On examination, mostly we usually don't find any cause on examination, but sometimes there may be a clue for the identification or advising further investigation. In general physical examination, the BMI is very important. Brax examination is important to find out that the patient is having galactorrhea or not. That can be related with the hyperprolactinemia. Pelvic examination will show about the uterus condition, size of the uterus, any pathology in the uterus, as well as the pelvic adnexa or association of any tumor like fibers in the uterus. Investigations are very important, but even after doing very important investigation, we are unable to find out the cause. The question is when to start the investigation. Ideally, after 3 losses, investigation should be started. But if we find some risk factor in the women, like elderly, or there is medical problem like hypertension, or family history of problem like inherited thrombophilia, then investigation can be started earlier. How to investigate? Investigate commoner and treatable causes first. We should not advise the complicated investigations which after which we are not able to treat the women. So we should start with the simple investigation which are and the condition which are treatable, and do not order blind screen. This algorithm is taken from the RCOG guidelines and show the how should we investigate a woman having 3 previous first trimester miscarriages. The initial investigations include anti-cardiolipin antibodies, that is IgG and IgM, plus lupus anticoagulant. This will exclude the phospholipid antiphospholipid syndrome. And then it is advisable that it should be done after the 12 weeks of pregnancy, like the pregnancy. If it should be done in between pregnancy, not during pregnancy, and two test positive 8 weeks apart are diagnostic for starting the treatment in the pregnancy. Second is the 3D ultrasound for uterine malformation. It is recommended as the gold standard to find out the congenital abnormalities in the uterus. But if 3D is not available, the 2D scan or routine ultrasound can help us in the diagnosis. Sometimes we can get help from the hysteroscopy as well as hysterosalpingography. That should be the second line of treatment when there is any doubt about the diagnosis of the problem. Karyotyping of the products of conception from third miscarriage. It is advisable to have the karyotyping. Then after there, if the karyotyping is abnormal, then the parental karyotyping if, is indicated, and it will not help in the management of the problem, but it will help in the counseling if abnormal karyotyping is found out in the couple. Thyroid function tests are advised, that is also important for the treatment and the management of problem. Then hemoglobin A1C for women with diabetes. The poorly controlled diabetes is another factor which can cause recurrent miscarriage. So these should be done in the initial investigations of the women. Now in this picture you can see that is the 3D scan showing different abnormalities, beautifully illustrate the different abnormalities in the uterus, double uterus, unicornuate uterus, bicornuate uterus, septate uterus, right? The other investigation which can be supplemented with the ultrasound are the hysterosalpingography. Here you can see that there are two body of bicornuate uterus having single cervix. Here you can see beautifully demonstration of two bodies of the uterus and the fallopian tubes. Nafsaltam says that if the saline infusion salpingography can help in the diagnosis of intrauterine pathologies, like if we infuse normal saline in the uterine cavity is distended, and the submucosal pathologies like submucous fibroids or the polyps can easily be confirmed if you don't have the facility of hysteroscopy. The genetic analysis of pregnancy issues not routinely recommended, but it could be performed for explanatory process. Genetic testing of POCs may be of psychological benefit to patients, as it could help provide them with the reason for the pregnancy loss. Couple may be benefited from genetic counseling and potential targeted therapies. Not having a diagnosis have been associated with feeling of uncertainty and frustration. It reduces the chance of women and the people pursuing non-evidence-based therapies in cases where no diagnosis have been reached. Conditions which do not need investigations are, according to the RCOJ line 2017, the ISHRI also advised not to do these investigations. That is the hereditary thrombophilia. And then it can be done in some cases where there is the history of second trimester and there's family history of hereditary thrombophilia. Then the male factor, that is the sperm defragmentation index is done. It's not recommended. Immunology, that is the natural killer cell, HLA typing, cytokines, not recommended, and it's outside the research context. We usually see that our many colleagues routinely advise the torch screening. Torch screening is not recommended in the diagnosis of the recurrent miscarriages. Torch stands for toxoplasmosis, other infections like chickenpox, chlamydia, etc. R is rubella, C cytomegalovirus, and the H is herpes simplex. For an infective agent to be implicated in the etiology of recurrent miscarriage, it must be capable of persisting in the genital tract. It means that if the infection is there, that infection will only be responsible for one time miscarriage at that time. It is not, it is not a cause of recurrent miscarriage in the woman. Okay. It is advisable to offer rubella immunity screening for pregnancy, recurrent pregnancy loss. That is important because if rubella IgG is positive, then there is no need to immunize the patient. But if the rubella is negative, then it is advisable to immunize the woman after the delivery of the baby. Management is multifactorial. Lifestyle modification, psychological support, specific treatment for any identified cause. One step recurrent miscarriage. There are clinics are available in highly specialized centers and highly developed countries where their dedicated clinical team is there, which manage the patient according to the evidence-based guideline. It's more extensive investigation and tailored treatment and supportive treatment. The function of one-stop recurrent clinic are these, that they are properly equipped for the diagnosis and management of recurrent miscarriage and also the counseling of the couple. Preconception management is very important because the whatever the risk factor, if we can avoid those risk factors before starting next pregnancy, it will be helpful in preventing the miscarriage. These are the weight reduction, avoidance of smoking, substance abuse, alcohol, diet, use of micronutrients, that is folic acid and vitamin D, male factor to add alcohol and smoking. The summary of the recommended treatment options are: the treatment option available. Some recognizable causes are listed here. You can see that the chromosomal abnormalities, in that we can do the PGT-A, PGT for structural rearrangement. Right, then anatomical abnormalities can be corrected, and the commonest abnormality which can be corrected are surgical correction of the uterine septum, polyps, and adhesions. Submucosal fibroids needs also treatment before the start of surgery. Thrombophilia, if there is congenital thrombophilia, that can be treated with the, and also the phospholipid antiphospholipid syndrome is treated once diagnosed before the treatment by using unfractionated heparin or low molecular weight heparin and low dose aspirin. Infections, mean antibiotics if evidence of infection, but prophylactic antibiotics are not recommended. Endocrinological problems need treatment like uncontrolled diabetes, disorders of thyroid, or hyperprolactinemia should be treated before the onset of next pregnancy. Treatment of subclinical hypothyroidism and thyroid peroxidase antibodies are not needed. Then in unexplained recurrent miscarriages, the role of progestin have been proved by evidence-based medicine. Then general measures which can be taken to reduce the risk factors are the maintain normal BMI, stop smoking, and tender love care, dedicated recurrent pregnancy loss clinic. Then caffeine should be limited. Now the treatment of thrombophilias, antiphospholipid syndrome. Meta-analysis have demonstrated that treatment of antiphospholipid syndrome with aspirin and heparin has got significant benefit. There are numerous studies as the strong evidence like the systematic review and meta-analysis that have proved that the treatment with the treatment in case of APS is beneficial in preventing the future pregnancy loss. Aspirin and heparin. Unfractionated heparin or low molecular heparin should be offered to women with APS, that is 75 milligram aspirin orally and 40 milligram subcutaneous enoxaparin for a positive pregnancy test until at least 34 weeks of gestation. Clinician and women should be aware that treatment with heparin, particularly unfractionated heparin, is not without some risk. Aspirin and or heparin should not be given to women with unexplained recurrent miscarriages. We have seen in our daily practice that some of our colleagues usually prescribe aspirin or heparin in the women who is having recurrent miscarriages without confirming that whether she is having APS or not. If the patient is having APS, then we start definitely with aspirin and heparin. But if this is negative, there is no need to start with aspirin or heparin. Inherited thrombophilias. There is a lack of evidence to support routine treatment for women to reduce incidence of recurrent miscarriages or second trimester loss. Anatomical factors. Congenital uterine abnormalities. Resection of the uterine septum should be considered for women with recurrent first or second trimester miscarriages, ideally within appropriate audit of research context. Acquired uterine anomalies. There is a lack of evidence to guide the management of acquired uterine abnormality associated with recurrent miscarriages. Counseling and choice of expectant versus surgical option ought to be individualized. Endocrine factors which need treatment, the thyroid problem. Thyroxine supplementation is not routinely recommended for euthyroid women with thyroid peroxidase antibodies who have a history of miscarriage. Thyroxine supplementation may be considered for women with moderate subclinical hypothyroidism, that is the TSH more than 4 million international units per liter, but it's not routinely recommended for women with mild subclinical hypothyroidism like TSH more than 2.5 milliliter unit per liter, irrespective of TPO status. Progestogen supplementation should be considered in women with recurrent miscarriage who present with bleeding in early pregnancy. For example, 400 milligram micronized vaginal progesterone twice weekly at the time of bleeding until 16 weeks of gestation. Unexplained recurrent pregnancy loss is another major problem for the clinician because it's very difficult to counsel the patient regarding the cause of the problem as well as the treatment of the problem and the success of future pregnancy. These women need psychological support and it should be offered ideally in a setting of dedicated recurrent miscarriage clinic. Then progesterone supplementation should be considered in women with recurrent miscarriages who present with bleeding in early pregnancy. For example, 400 milligram micronized vaginal progesterone twice daily at the time of bleeding until 16 weeks of gestation. The general treatment is the lifestyle advice, which include limiting alcohol and caffeine intake, stopping smoking, and maintaining a healthy exercise level and healthy body mass index. The micronized progesterone and NICE revise its guideline and recommend the off-label use of micronized vaginal progesterone. There the two trials occur, which is the PROMISE trial and the PRISM trial. These trials initially showed that there was no effect of micronized progesterone in preventing the recurrent pregnancy loss, but the second analysis in the PRISM trial shows that found that 3% greater live birth with progesterone but with p-value of 0.08. The prison sub-analysis shows further Hoc subgroup analysis that micronized vaginal progesterone was effective in women who have unexplained more than one previous pregnancy loss. Dydrogesterone have been proof as an effective medicine in the treatment of recurrent miscarriages. Efficacy of dydrogesterone on the treating recurrent miscarriage and its influence on immune system, a systematic review and meta-analysis issued in 2021. It says that it's a safe and effective synthetic progesterone and has sufficient clinical effect on recurrent spontaneous miscarriage. A double-blind randomized placebo-controlled trial investigating the progesterone demonstrated efficacy in women with recurrent pregnancy loss. HCG, that is human chorionic gonadotropin, is not enough. There's no enough evidence to evaluate the use of human chorionic gonadotropin during pregnancy in order to prevent miscarriage in women with a history of unexplained recurrent miscarriage. So, in majority of our colleagues prescribe human chorionic gonadotropin till the term till term. So it is not advisable. Unnecessary administration of the drug which is not effective will result in psychological disappointment in the woman as well as the cost of the drug. Now there few words about 17 alpha hydroxyprogesterone caprate. The article was issue which showed that the in the exposure of the women during pregnancy to the 17 alpha hydroxyprogesterone caprate resulted into the different cancers in the offspring. So after this study, the FDA withdraws preterm birth drug like Macana. 2.5 years after it first proposed doing so, the US Food and Drug Administration have made a final decision to immediately withdraw Mecana from the market. Hydroxyprogesterone caprate injection approved by the agency in 2011 to reduce the risk of preterm labor. After that, after withdrawal from by the FDA, the DRAP, that is the Registration Board of the Drug Regulatory Authority of Pakistan, has withdrawn all the products which contain the hydroxyprogesterone caprate. So it has been withdrew its approval for being carcinogenic and non-effective, official said. Now, the take-home message from this presentation is that the women should have psychological support, proper counseling, especially in unexplained cases. Investigation of common and treatable causes should be done first. Blind scanning should not be done. Consanguineous relationship does not increase the risk of recurrent miscarriage. No role of aspirin and heparin in unexplained recurrent miscarriage. No need to screen for infection, especially torch infection. Thank you very much for observing this presentation. I hope you have learned some new evidence-based medicine regarding the management of recurrent miscarriages. These observations and knowledge will help in managing your patient effectively.